Hi, everyone. Thanks for having me today. I just was learning more about your group and the hub, and it sounds like a really wonderful sort of group of people and like collective endeavor. So really happy to be here and to make some connections and hopefully stay connected to your group as time goes on. Um, as Amy mentioned, I'm a psychiatrist at St. Mike's in Toronto and also at Casey House. And, I'd say 80–90% of my clinical work is in the HIV world. Today, we're going to talk about HIV and some of its links to mental health and psychiatric illness with a real focus on trauma and PTSD. Save up questions for the end. And I'll do my best to kind of answer them as we go along. Um, so what are we going to chat about? We're going to talk a little bit about the interplay between HIV and psychiatric illness, focus specifically on PTSD as a diagnosis and the connection between HIV and trauma. And then we're going to talk a little bit about treatment approaches to PTSD, as well as, a little bit about what it means to provide and receive trauma-informed care in the systems within which we work. I don't have anything specific to disclose for this talk. And just to comment on kind of breaks and kindness to yourself during talks that might have content that might elicit some emotion in you or reaction in you, which can come up for anyone at any time. Might be related to your own story, the story of a client, a family member. So just sort of being kind to yourself, taking a minute to pause, giving space for yourself later in the day to come back to some of those feelings if you need to. I want to start by reviewing a concept that some of you who work in this field may have already heard of called the HIV care cascade. It's also called the care continuum and is essentially a concept that outlines this pathway that people move through the system from being at risk for contracting HIV all the way over to optimal health, where they have viral suppression and are linked to care. And I like the visual of this because it also allows me to understand where there are losses in the system, where there are gaps, and where we lose people who should be connected to care, who should be virally suppressed, but for various reasons aren't. One of the many reasons why we have losses in this care continuum is related to mental health or psychiatric diagnoses. So we're going to talk through three different cases that are all fabricated. So these aren't any one particular patient that I've ever seen, maybe a conglomeration of different people or entirely fabricated, but plausible. And we're going to talk about how at three different points in this care continuum, we can see losses secondary to mental health related issues. So case one is a trans woman, 27-year-old, who is on PrEP. This person is referred to me. I see them in my office referred by their family doctor because in the context of some crystal meth and GHB use, they've started to experience some psychotic symptoms, so some paranoia and hallucinatory experiences. So I'm talking to them about their substance use, about their psychotic experiences, and they start talking about different high-risk sexual activity that's happening while using crystal meth specifically. Um, this illustrates kind of right at that beginning of the care cascade. We've got somebody who is at risk, who is currently HIV negative, who's on PrEP. That crystal meth use, the substance use, the withdrawal periods are interfering with really good adherence to the PrEP, but they're still taking it with like reasonable adherence. But they're starting to talk about some really high risk sexual behaviors. So telling me that, the meth is leading to sort of more likely to participate in condomless sex with multiple partners, with folks who that they don't know their serostatus, and starting to become a little bit worried that their risk stratification has kind of escalated in terms of the possibility of contracting HIV. So, oh, sorry, that's just the hospital. Sorry. So an illustration of right from the get-go an at-risk individual, how substance use or substance dependence can get in the way of modifying risk factors in a meaningful way. Case number two takes us to the time of diagnosis. So, an individual who has been put at risk, acquired HIV, but not yet diagnosed. So, this is a 40-year-old single mother, originally from Zimbabwe. She is referred to me from her infectious disease doctor, and they had shared some sort of mood related symptoms to their ID doc. So, they referred on to me. I see this individual and she tells me about a very violent sexual assault that happened in her home country. And she suspects that this is when she contracted HIV. She back home had sort of suspected that she had contracted HIV, that she had seroconverted, and did not seek out any sort of diagnosis or treatment out of fear, and much of this being related to stigma. Um, and the other thing that she said, which was really meaningful, and I hear frequently, is that she didn't want to even think about the possibility of HIV because then that reminded her of the rape that she had experienced. And so there was total avoidance of this topic because it automatically led to triggering kind of feelings and re-experiencing feelings like flashbacks and nightmares. She was diagnosed with HIV when she came to Canada as a refugee on her entry medical, and so she learned of her status. But we're going to come back throughout this presentation and think about case two and how the trauma impacted her ability to accurately get diagnosed and accurately achieve optimal health. Case three is taking us to the end of that care continuum. So we've got somebody who has been accurately diagnosed, appropriately linked to care, a 55-year-old woman living with HIV for 2 decades. She had contracted it in younger life when she was engaged in sex work. She's had good antiretroviral adherence over the years. She's been undetectable, but she presents to me with an 8-month history of low mood, of anhedonia, which refers to it's one of the symptoms of depression, but a sort of a lack of interest or engagement in activities that previously brought somebody joy or pleasure. So she has this low mood, this anhedonia, some sleep and appetite changes, some passive suicidal ideation. And in the context of all of these symptoms, she's stopped taking her antiretrovirals over the last 6 months. And so I diagnosed a major depressive episode and got her on treatment for that, which then helped her get back on track with her ARVs. So we have an individual who we've seen really successfully travel through this care continuum, become virally suppressed, but then depression interferes with ARV adherence and we lose her in terms of achieving optimal health. And this is a really important piece because, when you go and look at the literature and review um, reasons for poor adherence or lack of adherence to antiretrovirals, one of the top reasons you'll see pop up on most lists is depression and specifically untreated depression. Why is this? Lots of different reasons. Some of it is directly related to the symptoms of depression themselves. So people can experience what we call neurovegetative symptoms, where their sleep is poor, their energy is low, their motivation is down. They don't have drive to, attend to appointments, get to the pharmacy to pick up their prescription. People can describe cognitive issues, so poor memory, poor focus. And people can also experience a real hopelessness. And some of that passive kind of suicidality can lead people to stop taking medications that they know they need to be healthy and to live. So, sort of three different cases that illustrate three different points in time in when mental health related concerns can interfere with one's ability to maintain health from an HIV standpoint. We're going to hone in on case two and the trauma elements and talk a little bit about PTSD and HIV. What does the diagnosis look like? What are some of those intimate links that are really important for us to be thoughtful about when we're working with folks who are positive? Okay, where's my... Oh, I didn't even change you to case three. I'm sorry. You weren't looking at what I was looking at. Okay, so moving on to PTSD and HIV. So the diagnosis itself. So the DSM stands for the Diagnostic and Statistical Manual of Disorders. It is a big book that psychiatrists use to accurately diagnose different conditions. So it's full of criteria for mental health related issues such as schizophrenia, bipolar disorder, social anxiety, post-traumatic stress disorder. And the DSM, in terms of PTSD, states that in order to have a diagnosis of PTSD, one must experience a traumatic event. They count a diagnosis of a life-threatening illness like HIV as a traumatic event. So from a diagnostic criteria standpoint, HIV in and of itself is considered a trauma. It doesn't mean that every person who's diagnosed with HIV will experience it as a trauma or go on to have a diagnosis of PTSD, but it qualifies them as experiencing a trauma from the DSM perspective. There are other life-threatening illnesses that also qualify as per the DSM. So you could think of a cancer diagnosis, for example. And yet we see the rates of PTSD higher for HIV than for other chronic illnesses. Why might that be? A number of reasons, some of which probably include sociocultural stigma that still exists for this virus. Some of it also probably includes a population that also already has a high level of pre-existing trauma prior to ever being diagnosed with HIV. So you've got somebody who's already sort of maybe potentially primed for experiencing mood symptoms or PTSD symptoms because they've already had a traumatized past. And it's sort of this double hit because HIV diagnosis or status itself can be perceived and experienced as a trauma. And also, as we know, many people will come to us with stories, such as the woman in case two, where the events leading to the infection were also a trauma. And so it's sort of this real double whammy that put these individuals at particularly high risk. But as I said before, trauma in of itself or an HIV diagnosis itself does not mean that that person is going to eventually develop symptoms of PTSD or get a diagnosis of PTSD. So about 60% of the general population in Canada has experienced at least one traumatic event in their life that the DSM would identify as a trauma. That could be exposure to or, threatened death, serious injury, sexual violence. But about 60% of the general population has at least one traumatic event. And yet we see in the general population, the prevalence of PTSD is about 7 to 10%. So, really, like a fraction of folks who experience trauma go on to develop PTSD. The concerning numbers that we see in the literature and that we see in our day to day work is that the prevalence of PTSD in people living with HIV, these are female studies, is actually closer to 30%. So, 3 to 4 times the numbers that we see in the general population, which is really concerning and just sort of highlights, that's like every 3 or 4 women I see have experienced trauma and likely meet criteria for PTSD. That means that 1 in 3 or 4 people seen in an infectious disease clinic or by a family doctor who sees folks who are HIV positive will meet criteria for PTSD. Do we do a good job at catching them in the system? I'm not sure. And so, with this understanding that trauma doesn't equal PTSD, we have to start thinking about what parts of a person and what parts of a trauma increase the chances that that individual who experienced that particular trauma might then go on to be diagnosed with PTSD. So the next slide is a bit of a pictograph that just sort of illustrates that the type of trauma is closely linked to the risk in terms of developing PTSD. So, for example, in men, the trauma that is most frequently associated with later developing PTSD is combat-related trauma. In women, it's sexual abuse and rape. So, experiencing that trauma, there's a higher chance that you'll develop PTSD. But you see things like, being in a natural disaster, a car accident, witnessing a trauma. The trauma rates are there, the PTSD rates are much lower. So then we have to start thinking about risk factors. So, what exists within a person and what exists within the trauma itself that put an individual at higher risk for developing PTSD? And I like to think about it as risk factors that exist before the trauma has even happened, risk factors that exist at the time of trauma, and then risk factors that exist after the fact. If we think about pre-trauma, um, the female population is already at elevated risk. Why is this? Likely because this female population probably higher rates of exposure to certain types of trauma. So that sort of the sexual violence, for example. There are some biological differences in the stress response and how our bodies process stress, and maybe a bit of a social cultural influence there as well. We see people who have a personal psychiatric history or a family psychiatric history also can be at higher risk for developing PTSD after a trauma. Low socioeconomic status, you'll see pop up on risk factor lists. At the time of trauma, a lot of this is sort of makes sense. So traumas that are more personal or targeted, violent, sexual or degrading, protracted or repeated. These are all elements of a trauma that can then increase the chances that one might develop PTSD after the fact. The experience of dissociation, for those of you who don't know, so dissociation is it's an experience. It's sort of a mental process whereby um, an individual will describe sort of disconnecting from their thoughts, their feelings, their body, their memories, um, and it's not uncommon at the time of trauma. It's almost like a survival mechanism in a way to sort of detach yourself from the horror in front of you. But it can cause problems for people down the road because the memories and the emotions get very fragmented. After a trauma, again, it's sort of what you might expect, but people who have sort of poor social supports, lack of access to services, if they've got substantial shame and guilt related to the trauma, and if they're dealing with significant physical pain. So, like, if you're in a horrific car accident and you've got all sorts of injuries and chronic pain related issues, that might increase your chances of developing PTSD related symptoms. And then something called acute stress disorder, which we'll talk about in a couple of slides, can also be a risk factor to going on to develop PTSD. I just want to take a minute, a slide or two to comment on interpersonal violence, which is an important thing for us to be thoughtful about when we're talking about trauma, particularly in the HIV positive female population. IPV referring to, domestic violence, so between a spouse, a common law partner, an intimate partner, and it doesn't. It's not just sort of a physical domain. So this can be sexual, emotional, financial abuse, um, and often sort of very controlling behavior. The the thing that's sort of very interesting, there was a review study of about a review of like 31, I think it was, studies in the US, with numbers that were pretty startling, like, a quarter to half of women experiencing physical violence and 20 to 40% experiencing sexual violence. This is women living with HIV. Really huge numbers of people experiencing trauma within their relationships. Um, Women reporting that sort of time of disclosure of status can be a really high risk time for violence within their relationship, and emotional violence that's very focused on their HIV status. So, stigmatizing remarks, threats of disclosure of their HIV status, or actually disclosing their status to others. And the other sort of upsetting aspect of it is that there's also a link to poor HIV health outcomes in this population. So women, HIV positive women experiencing IPV, 20% less likely to be on treatment, 50% lower adherence to medication, and about a third less likely to be virally suppressed. So that is linked to real morbidity in terms of ability to maintain, viral suppression, optimal health when we think about that care continuum. So the interpersonal violence is something for us to be really mindful of when we're working with female positive female populations. And again, I think something that we're not doing a good enough job screening around in the work that we do. This is sort of a pictogram of what we just chatted about, so I think I'll just skip over that. Yeah. Okay, so we're going to dive into a little bit more about PTSD itself and um, what it means to meet criteria for a diagnosis of PTSD. And I hope that this might serve to, allow you to be attentive to some words or symptoms that folks you work with might identify, and for you to then sort of link that to, like, I'm not sure, is this a PTSD thing? Should we get you assessed? Just to give you some knowledge of kind of what we go through when we do an assessment. So the first thing is that ASD, the acute stress disorder that I spoke about on the other page. When somebody experiences a trauma from that day to 1 month out, they might experience PTSD-like symptoms. We don't diagnose PTSD in that first month, and there's a few good reasons for that. One of the main ones being that we don't want to over-pathologize. So it's a normal human reaction to experience distress, anger, sadness if you've survived a trauma. Um, that's a normal reaction. An acute stress disorder would be sort of an extreme version of that. So meeting some symptoms of PTSD, but acute stress disorder, inherent within its definition is that it's time limited. So it's only within that first month after the trauma. Generally, that dissipates and goes away over time. PTSD, we usually look for symptoms that pop up like a month after trauma and can sometimes pop up even later, 6 months after trauma. It's a sort of a delayed expression of PTSD symptoms. But I think it's important for us, again, to sort of note somebody might experience a trauma and go on to have a normative kind of emotional reaction and move on with their life. Another person might experience a trauma, have symptoms of acute stress disorder, recover and move on. And a third pathway could be that a person experiences trauma, develops symptoms of PTSD, and then that's a more prolonged course of illness for them. Within the DSM, we have a number of different symptom clusters. So first things first, the DSM says that you need to have been exposed to trauma. That makes good sense when we're talking about PTSD. So this is exposure to actual or threatened death, serious injury, sexual violence in any one of these ways. So you can directly experience it, you can witness it, you could learn about it happening to a close family or friend, or you might have repeated exposure to it in the sense of like a first responder, for example. Like if they're showing up to a car accident, they weren't there at the time of the accident, but they're showing up seeing, you know, broken or dead bodies. They're seeing the aftermath of the trauma, and that sort of repeated exposure is also considered trauma. The second cluster of symptoms are referred to as intrusion symptoms. So these people will often share because they're distressing to them. So these are the nightmares, the flashbacks, the intrusive memories. When people describe flashbacks, they'll describe feeling like they are back in that moment. They can smell what was happening. They feel in their body what was happening. It's like they're reliving it and can be very distressing to people. These intrusion symptoms are usually sort of triggered by some type of psychological distress or physiological reaction. So something in their environment might remind them of the trauma, and then they might have a flashback, for example. The next symptom cluster is avoidance. So people will describe either internal avoidance, so I avoid thinking about it, I avoid feeling this particular thing because it reminds me of it, or they might describe external avoidance. I was assaulted on that street corner, so I don't go to that neighborhood. I don't like interacting with people who look like the person who assaulted me. It's sort of avoidance of external people, places, topics. The fourth symptom cluster is negative alterations in cognition and mood. This is the area of PTSD where there's like a real overlap with depression. So people will describe changes in their memory or concentration, um, existing in sort of a negative emotional state. They'll describe anhedonia. They'll talk about negative beliefs about themselves, the world, others, kind of these cognitive, negative cognitions that they've developed over time. I'm a bad person. The world is an unsafe place. People are untrustworthy. They're out to get you. These sorts of things you might hear people talk about. And then the final symptom cluster is alterations in arousal. So, this is the category of symptoms where people will talk about um, big, abrupt emotions that they feel out of control of. So, irritability. They might describe some reckless behavior. They might talk about one of the kind of common um, symptoms people will endorse as what we call hypervigilance. So these are folks who will, walk into a room and they're kind of scanning the environment, like where are the exits, who in here looks unsafe, how do I get out if I need to get out, and we'll also describe this kind of exaggerated startle response. If somebody walks up to me on the street and taps my back, I'm sort of like jumping out of my skin, um, sort of primed to be afraid. The DSM also says that this duration has this the duration of these symptoms or of the disturbance has to have lasted for greater than 1 month. So if somebody's coming in saying, I've been having these symptoms for a week, we'd probably be saying, okay, let's like keep an eye on this and see how it evolves. If they're coming in saying it's been 3 months or 4 months, okay, that would check my box in terms of timeline. It has to be linked to clinically significant distress or impairing their life in some way. So, some people might present with some of these symptoms, but unless it's causing them distress or getting in the way of their life, so getting in the way of relationships or ability to be a parent or to thrive in their work environment, if it's not linked to distress or impairment, then they don't meet criteria. And then finally, the symptoms cannot be secondary to substances or another medical condition. Um, or any medical condition, I think the DSM says. This sort of is meaning like if somebody's coming in and saying, I'm having, nightmares or some sort of re-experiencing symptom, but it only happens when I, smoke cannabis and my mind kind of goes to these different places. That then we would have to be a bit more thoughtful around, is that person actually experiencing PTSD or is this a symptom secondary to the substance itself? So those are all of this is like a summary. So there's more detail in the DSM in terms of what we go through when we're doing an assessment. But these assessments are one of, many different disorders that we would be typically be screening somebody for in a psychiatric consultation. So we would also be talking to them about anxiety disorders, mood disorders, substance use. If you've got somebody who is presenting with trauma and with PTSD symptoms, these assessments can sometimes take a long time and have to happen over multiple visits because when they're meeting us for the first time, they don't know us, they don't trust us, they may not, want to open up about something particularly scary or frightening that has happened to them. And that's also perfectly okay. So we'll talk a little bit about treatment and trauma-informed care. Trauma-informed care, I like to think about three different sort of domains: the environment within which we work, the assessments that we do, and then providers. What can we ourselves do to create a trauma informed environment? Trauma informed care is all about safety and control. Control for the person in front of us, for our client or for our patient. So, first, when we think about our environment and creating a space that is safe, um, there are lots of different things that you'll see in the literature when you read through, but some of the things that are relevant to the work that I do includes integrated mental health care. So, for example, at St. Mike's, I do a clinic every week in the positive care clinic, in the HIV clinic here. And so patients come to see that I'm an integrated member of the team, which allows them to feel a higher sense of safety and security when they're seeing me for the first time, if they've got trust with some of the other providers already. Really important to be sort of introducing our role, who we are, how we can help, and what the sort of structure of the appointment might look like. Also, really important to be reviewing confidentiality. People will often express anxiety around who's going to have access to these records. I don't want to tell you too much because I don't want everybody knowing this part of my life. So, reviewing kind of confidentiality can be helpful. And it's also important when we think about trauma-informed care. It's for our patient, and it's also for us as providers so that we are able to feel safe um, as providers ourselves. That allows us to provide safe care to the patients who we serve. Within the assessment itself, so part of trauma-informed care is actually screening for things that are trauma-related. So PTSD and interpersonal violence as two examples. As I mentioned, sometimes these assessments take repeat visits. So if I typically do a psychiatric consultation in 1 hour, if trauma is emerging as a particular problem for an individual, that might need to be revisited over 2, 3, 4 appointments before I really even get a full story and can make a clear diagnosis. And that's perfectly fine. It's also really important for us to provide choice so that the person sitting in front of us has a sense of control. Um, so for me, and in the work that I do, one of the roles that I sometimes play is around prescribing medications. And my sort of mentality and approach is always, you know, I think you have this condition. I think you have PTSD. These are the treatments for PTSD. I think you could do well on medication and it could probably help you with these different symptoms, but it's your body and you decide what goes in it. So I want you to have the information that this treatment exists, but at the end of the day, this is your choice, and I'm here to kind of go down whatever road you choose. And that sort of empowerment really kind of brings the power imbalance that can often exist in, a doctor-patient relationship or a caseworker-client relationship. It sort of rebalances things so that we're on the same page and on the same playing field. And this is sort of linked to what under providers being mindful of that power differential, giving the patient control, giving them some control and leeway over, guiding the assessment where they feel comfortable when they feel comfortable going there. And part of trauma-informed care, as I mentioned, is also screening. So when we talk about PTSD, there's I would say the most commonly used screening tool is the PCL-5, the PTSD checklist. And it's essentially a conglomeration of questions that align with the DSM criteria. So it's something that a client would do themselves, takes 5 or 10 minutes, and then the clinician would score it with higher scores, meaning like, this is sort of red flag potentially for this person having PTSD. It's not a diagnostic tool, it's a screening tool. So it would help you identify people who should go on to have a more thorough assessment. Interpersonal violence, there are some basic screening questions. You don't even need a tool for this. You really just need to be open to asking some of these questions of the clients that you serve. There was some good work done in Calgary in an HIV clinic there where they implemented some IPV screening tools, and they found that the prevalence of self-reported abuse, so patients um, reporting that they are currently in a relationship where there is IPV was 35%. So again, like really high numbers, and just shows you 1 in every 3, 4 patients that we're seeing would screen positive for IPV. So let's talk about how, oh, sorry, okay, on time. Let me go through treatment for PTSD, which is really multifaceted and has many different pieces of the puzzle. I think that the one thing to remember when we're working with folks who have trauma and who have PTSD is that we can only work at the speed of trust. So I can have lots of ideas about what I think would be helpful for a person, or this medication or that therapy. Um, there is no speed we can go other than the speed of the trust that that person has with me, the rapport that we have built. And if I try to push anything sooner than we have established that relationship, I'm sort of doomed to fail. Nothing's going to stick until that person trusts me and sees that I'm a person who's going to be consistent and who is sort of invested in them in a safe way. When when you think about trauma treatment, you'll see it sometimes categorized in different stages. So stage one is typically linked to safety and stabilization. So this is all about building trust. It's about teaching people some basic skills around relaxation, grounding, um, fostering self-care. So, related to like the basics, like sleep, diet, exercise. It can also be around some sort of psychoeducation around PTSD as a diagnosis and accurate diagnosis of the condition and accurate diagnosis of comorbidities. So do you have PTSD and depression? Do you have PTSD and a substance use issue, for example? If pharmacotherapy or medication is indicated, then it's also an appropriate time to start medication. So people will sometimes have some hesitancy about it and they'll say like I want to do trauma work, I want to do therapy work. And I might have a person in front of me who is, clearly destabilized from an emotional standpoint. And so one of the analogies that I'll often use is, you know, you're in the ocean, you're treading water and you're keeping your head above, you're staying afloat, but it's taking up a lot of physical energy, a lot of emotional energy. And it's hard to engage in things like therapy when you're treading water. You're working hard day to day just to stay afloat. Sometimes, not for everybody, but sometimes a medication is sort of the life preserver. It's the buoy that I can throw to you, that it's not going to get you to shore, but it's going to allow you to float. And when you can float, you can then start to expend energy on other things like therapy. So it will settle down some of those symptoms so that you can then actually do some of the meaningful work that will keep you well in the long term. And when we talk about medication for PTSD, we've got a lot of good options, a lot of good medication with really strong evidence for efficacy. Um, I think I said before, there's no real clear indication for acute stress disorder. So that's a time-limited diagnosis. That's the sort of trauma to 1 month where people can experience some symptoms, typically gets better and goes away. The medications that we use for PTSD are called SSRIs or selective serotonin reuptake inhibitors, which many of you may have heard of. These are the likes of Prozac, Zoloft, Cipralex, really strong evidence for helping people who have symptoms of PTSD. We'll also sometimes use medications from other categories. So SNRIs, these are medications that work on serotonin and norepinephrine. There's some evidence for some of the antipsychotics and also for a medication called prazosin you'll see used or doxazosin. These are medications that are actually blood pressure medications that were discovered to help specifically with nightmares and are very effective. Some medication, anxiolytics, and when I say anxiolytics, I mean mostly benzodiazepine type medications like the lorazepams, clonazepams. Those can sometimes worsen dissociative symptoms if you've got somebody who's describing a lot of that kind of detachment experience, feeling emotionally detached from thoughts, feelings. The benzodiazepines can sometimes make that worse. And then there are specific HIV related considerations when I'm prescribing medication. So I always need to be thoughtful about drug interactions. So is the antiretroviral potentially going to interact with my medication in the liver? Is that going to cause any issues? And then being thoughtful about some antiretrovirals having psychiatric side effects as well. So is this person on an ARV regimen that might be making the PTSD worse? Stage two is where the focus is on remembrance and mourning. So this is really the emotional processing of that trauma. It's the stage where therapy can happen and grief work can happen, with the goals being to sort of reconstruct some of these memories in a more meaningful way so that the person is able to move forward. There's lots of different types of therapies. one of the more popular ones that you'll see is called CPT, cognitive processing therapy. And this is a short term, like 12 to 16 session type therapy where people will work with a usually one-on-one therapist to sort of challenge some of their inaccurate beliefs related to their past trauma and create a bit of a narrative related to their trauma that allows them to kind of like process some of the guilt and the shame related to it. There's something called prolonged exposure therapy, which is a bit of an offshoot of CBT, cognitive behavioral therapy. And this is all about sort of recalling traumatic memories, but doing it in a safe, contained space. And maybe even with a stepwise kind of exposure to triggers, to allow somebody to go to a neighborhood that they hadn't gone to since the trauma, that sort of thing. You might have heard of EMDR, which is again exposure to trauma related thoughts coupled with sort of this oscillating eye movement. There's skills-based therapy, so dialectical behavior therapy has some utility in PTSD. And then there's IPT, interpersonal therapy, which is a type of therapy that I do. One of the focal areas in IPT is around transitions, which includes transitions to medical circumstances, such as a new HIV diagnosis. So while it's not trauma specific type of therapy, IPT, it can be very helpful in giving somebody space and time to process their HIV diagnosis. And then the last stage is often about reconnection and integration. So it's about empowerment, increasing one's capacity for joy, for pleasure, for positive affect, forgiveness. And, somebody might kind of go through to stage 3, come back to stage 2. And if at any point things destabilize, you're always going back to stage 1 to reinforce safety and grounding. If we apply some of this to case 2, so to our 40-year-old single mother who had the history of a violent sexual assault, diagnosed with HIV when she came to Canada, presented to me with PTSD and depression. So again, the step 1 is about building trust, fostering control. In this case, the first appointment was virtual. That really quickly felt like a bad idea. And both she and I agreed that being in person was going to really be important in allowing her to sort of know me, trust me, feel me in the room. And so we switched over to in-person visits moving forward. There was no time pressure on these diagnostic assessments. So, again, that 3 or 4 sessions to actually get a thorough assessment to give her the space she needed to talk about the trauma. There was social work involved to secure housing and to connect to community resources. And this individual was started on sertraline and prazosin for nightmares. She had also been prescribed Biktarvy, but there was nothing concerning from a drug interaction. But there were a lot of concerns about her ARV adherence, and she would describe this process of every time she takes the Biktarvy, she's reminded that she has HIV, and every time she thinks about having HIV, she thinks about the assault. And so a lot of the conversation and the work was around sort of tackling that idea so that she was able to take her medication and maintain wellness from an HIV standpoint. And she wasn't quite ready for therapy. She was kind of getting her life vest on and trying to stay afloat, but was interested in sort of down the road getting engaged in some therapy work. So I'm sorry I've run over a few minutes, but just sort of final thoughts. I hope I've illustrated that there is this complex interplay between HIV and mental health, psychiatric illness, and that the most common response to trauma is not PTSD. The most common response is distress and recovery, which is important to kind of reinforce the resilience and the skills that people have. Um, Trauma is subjective, and so that list of risk factors and others contribute to one's chance of developing PTSD. We see that PTSD may negatively impact antiretroviral adherence and then HIV morbidity. Um, and above all, we want to really strive for a therapeutic trauma-informed approach to patient care in whatever capacity you might work. Above and beyond everything is rapport and trust building so that we're able to kind of make meaningful connections and allow people to feel safe and contained in our environment. That's that. Thank you so much for your time and attention.